A very good morning to all. I bring you greetings from Armed Forces Medical College, Pune. The topic of my presentation is assessing relation between prescription analysis and medication adherence using general medication adherence scale in patients visiting OPD of a tertiary care hospital. According to WHO report, about 50% of chronically ill patients do not take medications as prescribed. The cost of medication non-adherence is about $289 billion per year and is a highly ignored area in assessing medication non-adherence, which is incorporated in GMAS, formulated by Naqvi et al. In 2018 and validated in 2019. This 11-element GMAS scale evaluates the medication non-adherence under patient behavior-related non-adherence, comorbidity or additional disease with pill burden associated non-adherence, and cost-related non-adherence, giving a total score of 33. This study aims to assess prevalence of medication non-adherence and its relation with prescription quality with the objective 1. To conduct prescription analysis using a validated checklist. 2. To study medication adherence and causes of non-adherence using GMAS. And lastly, to study correlation between medication adherence and prescription analysis. This is the study design. So firstly, we did a pilot study to establish internal validity in which prescription quality of the patients was assessed using a validated checklist that was formulated by the amalgamation of WHO Good Prescribing Guide, MHFW guidelines and literature research, and was vetted by the professors of pharmacology and hospital administration department AFMC Pune. Using this 27-element checklist, we audited the prescription quality of the patients and assessed and scored them. At the same time, of the same patients, we checked the medication adherence using the GMAS tool, a tool of PROM, Patient Reported Outcome Measures. So, as we analyzed the results of the prescription quality and the medication adherence, we tried to assess if there is any correlation between them. And we got a correlation coefficient of 0.6 that shows a moderately positive correlation and gave us a sample size of 29. Although we conducted our study on 150 samples, on prescription analysis, as we can see, the prescriptions were falling either under high, good or partial category. None of them fell into low or poor quality prescriptions. Although some of the demographics, some of the discrepancies that we found were all the prescriptions lacked capital writing and allergy status of the patients was not mentioned in any of the prescriptions. Therapeutic duplication was also nil. Although 42.9% of the prescriptions showed proprietary or trade name used, follow-up was not mentioned in 54% of the prescriptions, polypharmacy was seen in 20% of the prescriptions, and 12% of the prescriptions showed drug interaction. We found that medications prescribed in 25% of the prescriptions were not available in the hospital. Going ahead, when we assessed the medication adherence of these 150 population, we found that 53% of the population was adherent, 43% was partially adherent, and only about 4% was poorly adherent. When specifically we found that the cost-related non-adherence was seen in 16% of the population, and pill burden associated and patient behavior related non-adherence was 6 and 4%. Next, yes, thank you. When we go into the demographic analysis, we found that women were more adherent than men. And when we see the age statistics, we found that at the extremes, interestingly, in the extremes of the ages, that is less than 30 and more than 60 years, non-adherence was seen. While in between age group, that is 31 to 60, they tend to be more adherent than the other age group.
Dr. Ananya, you may now think in terms of concluding your talk, please.
Yeah, the monthly income, in the monthly income, the patient profile who were under the high income group, they were more adherent than low income group. Next. In the comparative analysis, as we can see, this is the blue line indicates the adherence score and orange line indicates the prescription score. As the prescription score is increasing, the adherence score is also increasing and vice versa. So we can see the scatter diagram also depicts a moderately positive correlation of 0.6. So we can see that so we conclude that a moderately positive correlation is established between medication adherence and prescription quality of the patients, which is also inclining towards strong correlation, as the value is zero point 0.6 and 0.7 and above are strong correlation. We also the tool that is used to assess the prescription quality may be used by other researchers also in similar studies, and also we can assess the causes of medication non-adherence. We can utilize these causes and improve our processes for better patient care, patient quality, patient satisfaction, and grow together. Thank you so much.
Thank you. It was a good presentation, but I felt your sample size was very less for a
Yes, ma'am.
AFMC.
Ma'am, in the pilot study when we conducted, so we got the correlation whenever we get a correlation coefficient, if it is 0 or 0.1, there is a sample size of 784 and 583. Then as the correlation increases, the sample size keeps on decreasing. Here the correlation is 0.6, which gives the sample size of 29, and we get the study results. But for better validity, we took the sample size of 150, that is 5 times the sample size we were suggested.
Thank you, Dr. Ananya. I think it was a very interesting study, and maybe you can continue with this and find more correlation between these two aspects. Thank you.
Thank you, sir.